uz padziļināto lekciju mēs aicināsim viesi no Vācijas, profesoru Ingolf no radioloģijas departamenta Berlīnas medicīnas universitātē. Tad došu vārdu viņam.
Thank you for the kind introduction, although I couldn't understand a single word, but I'm very much appreciating to be here. My first time in Riga, by the way, and I'm committed to say hello and my warmest greetings from Berlin. So you are all invited to come one day to Berlin. I hope you have been there already once. It's a beautiful city as well, maybe not as beautiful as Riga, but it's a good city to live there and to do research, especially in the field of biomedical applications of viscoelasticity. So I'm neither a physicist nor a physician. I'm a chemist, actually, by my education, but I promoted in the field of physics, and then I continued to do research in the field of medicine. So I'm in between all chairs, actually. This is what we call interdisciplinary research. And this is actually the most interesting, would say, interface of where innovations start. The interfaces between the disciplines. And the interface between physics, biology, medicine, this is covered by medical imaging. And medical imaging is actually one of the most important procedure and treatment a patient encounters with unclear symptoms. If you feel bad and you feel that something is not right in your liver, for example, you would consult your doctor, and the doctor would use ultrasound, for example, or MRI to look into your liver, right? And then people expect good images, actually, to see highly resolved where something is not at place and something is wrong with the tissue structure. And I guess you would be disappointed when you look at those images because they are not very well resolved. Actually, compared to the images you have on your smartphones, these images are almost empty. 120 times 120 pixel. This is a standard resolution in MRI, right? So these images have a very sparse content on information. However, this information is very valuable as it's a look inside the living body. And this is where we do our research, which is on using our tactile senses of palpation to make those sparse information images more informative, actually, to provide a better understanding what's going on in the liver or underneath the skin where you cannot look at. For example, breast cancer. It's recommended to women to palpate their tissues, their breasts, in order to detect hard, suspicious lesions by their fingers. And doing so, they would test the shear modulus. So this is actually nothing which has to do with the compression. Compression is pain. Compression to tissue means you change the volume. And you normally don't do this by palpation, by touching tissue. Instead, you shear the tissue. You preserve the volume, but you shift the tissue layers against each other. And the resistance against this deformation is actually the shear modulus. And this is a very informative parameter which we try to harness for medical imaging. And this medical imaging-based palpation is what we call elastography. So an imaging of elasticity and viscosity, as I will show later. So with this palpation, women are very sensitive to hard lesions in their breasts. At the same time, when they have a suspicious lesion or a suspicious finding, they would consult the doctor and they are transmitted to advanced medical imaging procedures, and then they see nothing. This is disappointing. As you see here, this is a case from our institution where we do not see any lesion here after mammography. So mammography is based on X-ray. It's just an attenuation contrast of X-ray beams in the tissue. And you cannot see here any malformation or suspicious alteration of the tissue. However, we have more than only one modality. MRI is a very important imaging modality for soft tissue contrast. And with MRI, you see a lesion here. However, this MRI has been performed with contrast agents. So contrast agents in MRI alter the relaxation times of the signals. They are mostly based on gadolinium, which has a very high capability to alter the magnetic properties of the water signals in the tissue. Therefore, gadolinium is administered, and this gadolinium is enriched in those tissues which are highly perfused, and this is a characteristics of tumors, that they perform an angiogenesis, how it's called, so the build-up of new vessels to feed themselves with energy and nutrition, and this brings such a positive contrast of the contrast agent accumulated in the tumor. So here it's visible with a positive contrast. In ultrasound, you also see it very well. Here is something suspicious. This is at the same position as here, but it's difficult actually to register those images to each other. Nowadays, in multimodal imaging, all these data are acquired sequentially in the follow-up procedure of different imaging modalities, and all the data are stored in the so-called DICOM format, and they are transferred then to the ultrasound scanner. And in ultrasound, then you can overlay the image which you see in real time, so it's a very fast technique in contrast to the other imaging modalities here, where you navigate through with your ultrasound transducer, and the field of view can be matched to what have been acquired previously in the MRI. So this is already a big advancement and a big step forward to multi-contrast parameters. And this is important, as a single contrast does not help here to distinguish benign lesions from malignant lesions. And this is another problem in medical imaging. Nowadays we are very sensitive, what means we see everything. In one of the toolbox of modalities, we can see every single lesion. However, we all have lesions in us, right? But they are in very rare cases malignant, so they are not dangerous. And it's always better to not touch a benign lesion, which is not dangerous. Leave it at place, don't touch it, than over-treatment, right? Then getting to the surgery and excising the lesion or initiating chemotherapy if the lesion wouldn't be malignant, right? So patients suffer a lot from over-treatment. Therefore, we need multiple contrast mechanisms to reach a higher specificity, as we call it. Sensitivity is important to detect everything, and specificity is important to select out the malignant lesions where we have to act on in comparison to those which we leave. Well, and one very important set of parameters is the elastography, which is in ultrasound already implemented in all commercial scanners. Well, and they provide an overlay of colored pictures where you can estimate if this lesion is stiff with respect to the surrounding, or is it more normal. However, it's still open and a research question, what is normal and if stiffness at all helps here. Well, and then the normal procedure is biopsy still. So we need to punch out tissue here from the lesion under ultrasound guidance. You see here the channel which is induced by the biopsy needle, and then a piece of tissue is taken out of the lesion in order to look under the microscope how it looks like, and if there are cells in this lesion which are on the verge of malignant transformation, they display certain patterns which are also not easily to detect. Therefore, we need trained pathologists which look through the microscope all day long. So this specialization in medicine is nowadays in big centers very well performed. Guys who look through the ultrasound all day long, so they perform thousands of examinations over a year, and the same for the pathologists. And when they play together in the right manner, then we can achieve at optimal diagnosis and can come to optimal treatment plans. However, how does it work, this elastography, and can we make it more informative? So the problem, as you might have seen, is that this current elastography provides a kind of stiffness contrast, right? But it does not reach very deep. So it's good for the breast or underneath the skin, but it's not good for the liver. The entire liver cannot be covered, and it's not good for the brain, for example, for brain tumors. What we need to do elastography is we have to touch the tissue, right? It's like palpation. So this can be done in a static way, just from the surface, but we want to get deeper, for example, into the brain. And here we can use acoustic waves, right? So just by acoustic sound sources, sending waves through our body, as in standard daily life, where acoustic waves are always penetrating our body. So we can capture those waves with imaging modalities like ultrasound or MRI, and then calculate stiffness maps, which we call elastogram. So which show here the wavelengths here in the middle, for example, of the simulation is a bit larger than outside, and after conversion to stiffness maps, we see here a firm inclusion and a soft background. Well, as you are interested in physics, right, I would like to stress a bit here about the nature of the waves we are transmitting to the body in order to perform elastography. And this is a mixture of longitudinal waves and shear waves, actually. We always would induce shear waves and compressional, what means longitudinal waves, at the same time when we are exposed to a loudspeaker. A loudspeaker sends acoustic waves, so this is a compression wave with a speed of sound in tissues about 1,500 meters per second. So it's quite a very fast wave, meaning having a very long wavelength. And those acoustic waves perform mode conversion on each slip interface, where they get scattered. The scattering converts compression waves into shear waves. And the shear waves, this is what we want to see. This is our desired source of contrast in elastography, because a shear wave is sensitive to all these connectivity activities inside the tissue on a cellular level. This is what we feel with our fingers. This makes palpation so incredibly sensitive. And therefore, the shear modulus varies over orders of magnitudes from almost 0 in liquids to gigapascal for bone, for example, right? And this wide variety of parameters, this is what we want to image with elastography. In contrast, the compression modulus is related to the water content in the tissue. It's also interesting, however, it's not varying very largely over the body. So the water content in soft tissue, you know this probably, is in which range? Do you have an idea? How much water has, for example, the brain? If you would try it out. Yes? 80? Yeah, 80%, so 78%, something like this. This is the water content in the brain. Do you know the water content of the kidney? It's similar, bit higher, in the order of 82%. And do you know the water content of blood? Blood. It's liquid. 78. So blood has less water than the kidney. The kidney has a shear modulus on the order of 10 kilopascal. The blood has a shear modulus on the order of 0 kilopascal because it's a liquid, it does not transmit shear waves. So this already tells you about the importance of the connectivity of ligaments, for example, or cells in the tissue for the palpable properties, the haptic properties. One is stiff and a solid, while the other one is a liquid, right? Although the water content does not tell you here which is which, right? So this is interesting, and this even more interestingly changes a lot when tumors progress from a fibrotic state to a malignant state where tumor cells are able to leave the tumor boundaries and to spread through the body by metastasizing. Okay, so there are different modalities which use elastography, as I said. One of the most widely used elastography modality in ultrasound, meanwhile, is based actually on a push pulse of the ultrasound transducer. So you can focus the ultrasound in a way that you can burn tissue, right? So ultrasound is actually a dangerous modality if you are not careful with that. You can easily burn the tissue, which is ablation. And this is used actually also to treat tumors by ablation, by burning them if they are near the surface, right? Or you can destroy gallstones with ultrasound. So just focused ultrasound is very powerful. And in a implementation where it does not destroy the tissue, but it displaces soft tissue, it can be used for elastography. Just with a little push, it's starting to vibrate the tissue underneath the surface in an order of, at maximum, 6 centimeters away from the surface. You still can vibrate the tissue, and then you would induce here, where I am now? Here, okay. You would induce here such a point source for waves. Or if you shift the point source very fastly away, then you can induce those cones of waves which propagate away. So from a physical or from a physics perspective, this is a perfect scenario for elastography, as you have a well-defined point source and you just need to measure the propagation speed of these shear waves, which transversally propagate away from the point source, right? So if you push along this way, the shear wave is emitting transversally to the source. The original ultrasound elastography modality was transient elastography, which is meanwhile not much used anymore because it's not imaging resolved. It's just using a short burst of 50 hertz vibration, something like bloop, and well, that's it. Then the wave propagates into the tissue, and along a beam you can track here the propagation of the wave. What we use here is time harmonic elastography, where we continuously vibrate the tissue. I will show in a minute why we use this technique. The beauty with time harmonic waves is that you precisely know the frequency with which you vibrate. Therefore, time harmonic meaning it's a sinusoidal continuous vibration we induce from the outside of the body. And you can capture those waves with MRI. This we call MR elastography, MRE. With ultrasound, where we call it time harmonic elastography, THE. Or recently we developed the same for microscopy in order to look into tissue samples on a microscopic level. And here we look at optical displacements, which can be also evaluated in the same way as THE, MRE. So we use this in OT, so optical time harmonic elastography. As said, the acoustic radiation force technique sets a little pulse here, a small pulse, and then the wave is propagating away. Transient elastography has this burst, and time harmonic elastography continuous vibration. And here you see already in the simulation, along a spatial and a time axis, the advantage of this time harmonic approach, as we have a much stronger illumination of the body deep into the tissue underneath the surface, including the brain, right? Where you can see with a slope in this X-T plot what the shear wave speed is. And the shear wave speed is directly related to the shear modulus. So this is actually a proxy of shear stiffness. Well, these are the modalities for this time harmonic elastography. And as you see here, the pixel size in the image varies from 2 millimeter, which is a standard pixel size in clinical MRI. I must say it's not only MRI of the liver. So therefore, these images are almost empty, right? If you have such big pixels, it's like a staircase more than a well-resolved image, right? Nevertheless, images look like this, and here you see in the color contrast stiffness. So greenish colors indicate soft tissue, reddish colors are more stiff tissue here. And the same we can apply in high magnetic field preclinical MRI scanners in order to investigate models of diseases like tumor models in the mouse. So this is important for development of treatments of drugs against cancer, for example. And the same has recently evolved in the bioscience community with fish. Zebrafish is a very viable model, meanwhile, for tumor research. And therefore, colleagues came to us and asked for elastography in zebrafish. And here we succeeded with this optical time harmonic elastography. And you see the frequency of the stimulation is increasing with decreasing pixel size. So the overall matrix we can acquire is almost the same, 128 times 128 pixel, but the pixel size, of course, decreases in order to cover here smaller fields of view with higher resolution in the fish, in the mouse, or here in the human liver where we have bigger pixel sizes. Okay, this is a current setup for the induction of the shear waves in the patients. So this is our current setup. Don't know. Do we have loudspeakers here? Maybe I can. turn on the sound. This is music to my ears. I love it. You see these little bottles here, and now this is higher frequency. This is 60 hertz, I can tell. Okay, these little bottles here are printed, plastic bottles, connected to a compressed airstream, and the airstream is just switched on and off with magnetic valves. So very simple principle and very robust. And this is good for frequencies up to 200 hertz. So it's non-magnetic, non-metallic. This is important, as we have to bring it into the MRI. Okay, and here is a setup of our optical time harmonic elastography. As you saw here, we have different frequencies which we apply sequentially. So this takes time. While here in optical time harmonic elastography, we are much faster because we can capture with light much faster the images. That's it. This was the sound of elastography with the optical setup. Okay, I love it. The colleagues in the same lab here, they hate it to hear it all day long, this bloop. But Jacob, who developed this technique, he optimized the frequencies in a way that we fit exactly the same frequency range we have in our preclinical MRE settings from 800 hertz to 2400 hertz. And these are the frequencies you just heard, just superimposed. Oh, no, it's not superimposed, it's wrong. No, it's sequentially, but very fastly after each other. So I think it's in the order of 20 cycles. I'm not sure. 20 cycles for each frequency, and then with increasing frequency, the tone gets higher, right? And the trick is here that we have a precise control of the vibration, right? And we capture just a wave phase with a stroboscopic shift. So our imaging modality is slower than the vibration. It's something like a camera with a slow frame rate of, for example, 20 hertz or so, captures the rotation of a wheel, right? Then you see suddenly in the film the wheel is spinning backwards, right? And this is the stroboscopic effect. And this is what we exploit here in order to capture very fast vibrations with a relatively slow imaging modality. However, we need to have a precise knowledge of the timing. And this is a so-called periscopic animation, which got quite attention 100 years ago on the market, but we call it Augentäuscher in German. So you can produce such fake images actually, and this is what we do actually as well here in elastography. This is a fake image of the vibration. So the vibration is of course real, but the timing of these waves here is not real. It's much slowed down due to the stroboscopic sampling. But nevertheless, these waves can then be analyzed spatially in order to obtain elastograms. So here you see how it looks like in different modes for the deflection. So we have field deflections along the vibration directions and perpendicular to this, and here out of plane. And these wave images match very well our simulations, and they can be fitted simply by Bessel functions, and this gives us a perfect match to the underlying stiffness. And here's an example in zebrafish. You see here the wave image animated, how the waves propagated through the fish. This is, to our eyes, not very informative. However, after reconstruction of stiffness, we see here details which are totally new. This is a contrast of stiffness which is not revealed by normal optical contrast. So optical contrast is seen here, while the stiffness contrast is here on this right side, color-coded. And here is in grayscale, because the eye is better in perception of small details in a grayscale image. Therefore, we normally use grayscale images. However, now back to clinical imaging. We have to get the waves into the brain, for example, when we want to do brain MRI, right? So this is an exaggeration. So we just need a little cradle to induce the waves from the back of the head. So as I showed you, we use these printed plastic bottles. Here we used 4, for example. This is our standard setup, meanwhile, for the brain elastography. And then MRI captures the waves. So we need actually only a modality which is our photo apparatus, right, which provides us the wave images. Doesn't matter where the waves come from, but the timing has to be very precise. And here you see 3 different frequencies of shear waves propagating through the brain. This here is 30 hertz, 40 hertz, 50 hertz. So with higher frequencies, the waves become shorter. This is the standard relationship, linear relationship of wave number and the frequency, vibration frequency versus shear wave speed. This is our setup for body and abdominal MRI, where the sequence here has a motion encoding gradient, controls when our shear waves are actuated and excited in the tissue, and the sequence, of course, also controls the MRI scanner. We have a wealth of information which is acquired within 5 minutes only. So as one MRI image is acquired within one shot, it takes about 100 milliseconds, right? And this is repeated for each slice through the brain and for each time step over the vibration cycle. So as seen here. So normally we have to repeat 4 times, 6 times, or 8 times over a vibration cycle. We have to repeat the experiment at different encoding directions in order to acquire the entire field of the shear waves. And we have to repeat this for each single frequency we want to examine, we want to test here. So overall, it takes 5 minutes, as said, and this provides us this overall set of information which we plug into our inversion algorithm to convert this raw data, phase information, into stiffness maps, as seen here in tumor patients of the brain, where you see that this tumor here, which is actually in the normal magnitude MRI image, so this is a standard MRI image here, the tumor is not very well delineable from the surrounding edema, right? So the edema looks even brighter than the tumor. However, the stiffness map here shows that the tumor is almost liquid, right? And the wave penetration and fluidity, I come later to it, this is the viscosity information, which is also very important to characterize the mechanics of these tumors. However, we see also tumors like this one here, which is not significantly different in stiffness. So the surgeons, during operation, they wouldn't feel that this tumor is much stiffer or softer than surrounding tissue, right? While this can be even sucked out. So this could be treated in a totally different way than this one here. Here you need a knife, and here you need just a pipe to suck out the liquid. So something like this is very, highly desired as a pre-operative information from the surgeons. And here this tumor is slightly softer, but it sits at a very dangerous position in the brain stem, and therefore it's not only, of course, the mechanics, but also the surrounding or the niche, the pocket in which the tumor sits, which matters here. Well, ultrasound elastography is complementary to MRE. However, in the brain, it does not provide as good images as MRI, for example. But as said, we can use the same physical principle of shear wave introduction into the body. It's much simpler in ultrasound than in MRI because we can use metallic parts. We can use loudspeakers, standard loudspeakers actually. This was our first generation patient bed for vibration induction into the thorax for cardiac elastography. This is our second generation. Here we have a voice coil underneath this red bar here, which can be placed at the position where we want to investigate the patient from the head to the thorax to the abdominal region. So the voice coil is a kind of strong device which is normally used in cinema seats to provide you a kind of four-dimensional perception of the movie, right? So at a scenario where an earthquake comes and the seat is shaking, for example. So very fancy way of getting or raising the excitement of the audience, right? And we use the same devices here for shaking the patients, which is quite, I would say, a safe procedure if you can use it in cinema. So we can also harness this for diagnostic imaging. But to make it more available to other departments and clinics, so we have now a smaller portable device which we can just put underneath the patient's head or thorax in order to perform this elastography. And this is a display of our setup for ultrasound elastography of the brain. So in a transtemporal way, you can also obtain a limited contrast from the brain with ultrasound. Although the images are not excellent, they have enough information to encode the shear waves. And this is where we are interested in. So can I display? Okay, it doesn't work here. Normally this is a movie, just a short movie showing how the waves propagate here through the brain. And as you see already, it looks quite similar to what you have seen with MRI elastography. However, this technique is much, much cheaper. So this is really a point-of-care technique which can be brought to physicians in their departments. And although the images look not very detailed, actually, so overall contrast tells you a lot about the pressure state in the brain. And this is something where surgeons, so neurosurgeons, would do everything to get a non-invasive measure of pressure. And this pressure shear modulus coupling in the brain is really something where this time harmonic ultrasound elastography could contribute. Okay, here, this is just how we process the data, as you might be interested in as physicists. So how look raw data in this type of application? You see it's quite noisy, but you already see here waves. We need bandpass filters to suppress compression waves on one hand and noise on the other hand, and the remaining waves here can then be filtered by directional filters. So we just look into the wave propagation along different directions, and then we combine all these directions at different frequencies in order to arrive here at such a frequency compounded elastogram. And as said, this pressure shear modulus coupling in the brain is something which, on one hand, we don't understand yet, but it's there. We don't understand that it's not there in MRE, but in ultrasound elastography we found a huge sensitivity with in patients with intracranial hypertension. So there is a disease which is called idiopathic intracranial hypertension, which affects women. So, and it's not known why women, only women, no men. I mean, at least 90% of the patients are female. And they are relatively young, and there is no therapy actually, just that a relief of the symptoms. So they suffer from headache, for example. And a relief of these symptoms is achieved by lumbar puncture, where just from a spinal tap, CSF, cerebral spinal fluid or liquor, is drained out of the spinal channel, which relieves the pressure in the brain. And it's still not clear. Sometimes it helps, sometimes not. It's an invasive procedure which is associated with risks, and physicians would like to avoid this procedure, of course, if it doesn't help. And in our cohort study here, in this pilot study, we saw indeed some cases where it didn't help, and these were already in the normal range of healthy volunteers before this lumbar puncture, and it didn't change much here. While all the others showed a steep drop of shear stiffness, which is here obviously related to this procedure, because we measured the shear stiffness pre and post lumbar puncture within a time frame of 5 minutes, right? And this, I must admit, this is the clearest effect of stiffness change we ever observed in the brain. So the pressure shear modulus coupling in the brain seems to be a quite efficient way to develop such a non-invasive probe for intracranial pressure. Well, actually our initial motivation to develop time harmonic elastography based on ultrasound was cardiac applications, because the heart muscle changes stiffness while function, right? So it's even vice versa. Heart function is defined by the change of the shear modulus, of the stiffness of the myocardium, because this is one-to-one translated in the generation of the cardiovascular pressure, which propels the blood through our cardiovascular circuit. And therefore, cardiac elastography is the way to go when it comes to functional assessment of the myocardium. However, there's no technique out yet which works, right? This is something we have to, I mean, I'm here to tell you also the current challenges, and it's not yet done. What we could do so far, we used our standard vibration bed with our standard pipeline to produce such maps. So it's a very robust and simple way. We have no control here about the way how the waves are introduced. If it's really a shear wave, a compression wave, what is the deflection direction? It's so complicated in the heart that we have to omit all these rigor physical principles here. Instead, we send our waves into the thorax, into the heart, and then we do image processing. And we say something what we can reconstruct here is related to the stiffness. So we call it the apparent stiffness of the heart. So even in the blood pool, we see an increase of stiffness, which reflects the stiffness of the surrounding myocardium, but of course not the stiffness of the blood. However, I mean, if you look at it very picky, and you look at it as a physicist who knows very well the theory about viscoelastic wave propagation and generation, then you would say this is wrong because you see stiffness here in the blood, right? Well, we don't see it in such an extent in healthy volunteers, but we see it in patients with this ATTR amyloidosis. So this is a terrible disease, actually, which causes fibrosis in the myocardium. And the heart cannot relax properly anymore. So in this relaxation phase, the heart is much, much too stiff, and these patients suffer terribly. But there are therapies. So it's really a diagnostic challenge to identify those patients from other groups of patients or from healthy volunteers. And surprisingly, after tweaking our pipeline to image processing, filters, etc., we see green maps for healthy volunteers and red maps for patients. We thought this is something which the community should embrace, because this is quantitative imaging, it's physics-based, it's elastography, it's simple and cost-effective, and it's a point-of-care modality. The opposite was the case, actually. We had, and still are having, such a hard time to publish this study. Although it's proven in 150 patients, reviewers don't believe us. They say it's wrong because you see stiffness in the blood pool. Well, we will see where it goes. So we know, based on other experiments, that of course the blood and the liquid in a lumen vibrates with the wavelengths of the surrounding walls. And if the walls stiffen, then also the wavelengths increase inside the liquid. But all those aspects are very hard to prove and validate in vivo. And we don't want to go this way. We just want to bring it onto the market. We want to get it into the clinic. Well, and this is our current objective here in this study. I don't know how much time I do have left, or how is your attention tolerance. So I have prepared a few slides for viscosity. Maybe you are interested in that, then I continue here with just 3 to 4 slides how viscosity could help us to characterize the mechanical properties of tissue. So we measure the shear modulus, right? So this is our basic measurement parameter, or shear stiffness or shear wave speed, but this is related to each other. And the shear modulus is a complex quantity in a frequency domain, right? So complex quantity means you can represent this as a magnitude quantity and as a complex exponential function with a phase, right? So this phase is what we try to recover in addition to the shear modulus here in order to get insight into the viscosity of the tissue. And while the spring constant in such a system, which is an undamped system, is related to stiffness and the elastic deformation of a body, so meaning that the deflection of a sinusoidal curve follows exactly the stress which you apply. Putting some thick liquid into such a damper, right, would delay the response of this sinusoidal deflection curve to the stress. And this delay is seen as a phase shift here, and can be measured as a phase shift. So it's a time response to the stress, and this is what we see as viscosity in our time harmonic elastography. So on a very basic level, we have different vibration frequencies, and in a perfectly elastic material, we wouldn't expect any dispersion of the shear modulus over frequency. What means dispersion here is just a constant. The shear modulus does not vary with vibration frequency, right? So this is a perfect elastic material, like pudding, for example. If you tip against it, you can see the vibration still a second later, right? So the vibration is very well preserved and restored. In contrast, soft biological tissue can be as soft as this pudding here, but has, of course, totally different haptic properties. And this difference, this distinction, goes back to the viscosity in this material. So shear modulus can be the same, but of course the viscosity is different. Therefore, the the structure is different. Therefore, the viscosity is different. What means the damping behavior, the attenuation properties of shear waves are much higher, and this has a consequence that the shear modulus increases over vibration frequency. Right? So both start here with the same low level of shear modulus at low vibration frequencies in the quasi-static regime, but this soft biological tissue would feel much stiffer at higher vibration frequencies than the purely elastic material. And there are scenarios where you have stiff viscoelastic materials like rubber, for example, and stiff elastic materials like a metal spring, for example, right? So these four scenarios in a two-dimensional parameter space can be shown in order to explain a bit the parameter range we measure with our two parameters, stiffness and viscosity. Here, elasticity on one, or stiffness on one axis, and viscosity on the other axis. And the healthy liver is a very soft material, but it's quite viscous, right? It's or has almost liquid properties, at least in a higher frequency range. It behaves more like a liquid than a solid, but it's very soft. So hepatic fibrogenesis or cirrhosis is associated with stiffening of the liver. It's much stiffer, but it also feels like a different material as it's more rubber-like. So it becomes more towards low viscosity materials like a spring rather than a viscous damper material. So this is what we see here as an example when we apply MR elastography to patients with hepatic fibrosis. And this is actually the standard application, meanwhile, in the clinic for MRE to stage hepatic fibrosis and to identify patients on the risk of liver cancer. But we performed other experiments, for example, in muscle. You see an increase of stiffness here from muscle contraction. This is a relaxed state, and this is a contracted state. And at the same time, the viscosity increases. This was surprising to us. So muscle is very damping, so very lossy tissue, and this loss property is even increased upon contraction of the muscle. The aging brain gets softer and less viscous. This is what we observed in ourselves. So in our brains, we saw that the brain becomes softer about 0.3% a year. In the adult brain, from 18 to 88, we saw almost linear decline of stiffness. So, well, I'm now in the business here since 10 years with the brain MRE, since we published this study for the first time, and I need to admit that my brain has become softer about 3% in this time. So it's a bit scary, but at least I can live with that. So it's no problematic. It becomes problematic when this process is accelerated and there is a premature softening and conversion of the brain towards less viscosity. And this is what we see in patients with chronic inflammation like multiple sclerosis. So this is a technique where we might identify treatment effects. So multiple sclerosis can be well treated nowadays, but with very subtle and delicate adjustment of therapies. Therefore, we need here a quantitative follow-up technique which does not use contrast agents, because we don't want to administer in a follow-up investigation gadolinium-based contrast agents to young patients. Because during the last 6 years or so, it became evident that gadolinium is accumulated in the dentatus gyrus of the brain. So in certain brain regions, you find a higher level of gadolinium after one single MRI scan with contrast agents, right? And this is what physicians try to avoid now. So for follow-up investigations, we need techniques without contrast agents. And so MRE could be an alternative here. And this brain degeneration we observed in Alzheimer patients and patients with hydrocephalus is much accelerated than with progressing degeneration. Well, in the end, I would like to summarize. So time harmonic waves can be used in elastography to test for ECM cross-linking, cell adhesion, vascularization, necrosis, all these microscopic tissue remodeling processes which are not apparent to the imaging modalities on a coarse-grained scale, on a millimeter range, right? Therefore, we need here techniques which provide sensitivity to such micro effects. And elastography, the shear waves, is a neat technique to sense those micro tissue interactions. And it's completely safe. It's not based on contrast agents, and it just harnesses all the waves which penetrate our body in the normal daily life anyway, right? The MRI scanner is a very noisy and loud machine which induces a lot of acoustic noise, and we can actually use those waves for elastography. However, we do it with our extra actuators because the timing is better controlled. However, when I'm volunteering for our own study, so meanwhile I can sleep even with brain MRE, and I cannot recognize the difference of the vibrations coming from the MRI scanner or from our actuators. It's a minimal deflection, and this doesn't hurt. Well, so this ultrasound time harmonic elastography, I think this is a way to go for organs like the heart, which move very, very rapidly. And here we have to make our physical compromises with the rigor of the wave equation. Therefore, the wave images or the reconstructed maps are not perfect, but they provide a contrast which is very useful for the diagnosis. And it's easy to apply, so it's a point-of-care modality. And this optical time harmonic elastography is a perfect research tool, as it's cheap. We have this stroboscopic sampling. We just need a high-speed camera. Any microscope can be used, or even normal optical lenses. And then we use the same processing pipeline as we have developed for MRE. Okay, at the end, I would like to thank my group in Berlin and our collaborators, and of course, all the funding agencies which provide the money to do our research. And I would like to thank you for your attention. You are a great audience, and I'm happy to be here in Riga.